So arteriovenous malformations in the brain, they can be divided by location or just enumerate them as they are. The first thing is by location is the dura, the arachnoid and the pile. And the spaces are in the dural space, subarachnoid space and subpile spaces. There are some malformations which are in different spaces which will include the skull, the bone, the skin, subcute, dura as well as the brain, and they are metameric malformations. And CAMS is one of them, which includes the face and the brain, that is cerebrofacial arteriovenous metameric syndrome. When you look at the arteriovenous shunts in the brain in children, these are the basic 4 malformations or the lesions that they are. The most important, the commonest, and probably the most challenging is the vein of Galen aneurysmal malformation, which has its 2 types, the mural and the choroidal. In dural, not many of us know about this, and so I will spend time when we get to it. In dural, we have sinus malformations. They might be without or with high flow shunts in the dural sinus. AVM is like any other pile AVM, even in adult patient with fistula or onitis. And as I said, the cerebrofacial arteriovenous metameric syndrome or CAMS. The presentation in these malformations is with headaches. Many of them, especially the vein of Galen's, will have a large head, and if the parents, as very often happens in India, if it is neglected or if it's thought that the child will be okay after a few weeks or months, it doesn't happen, and that leads to delayed milestones and sometimes permanent damage in the brain. Very rarely these malformations bleed. The ones which bleed are pile fistulas most commonly. They have progressive neurological deficits, and if it's too late, it's late for us. We should not treat them if the child has a melting brain syndrome. Sometimes it's an emergency because the child will come to you in refractory cardiac failure, and again it's too late if the failure has led to multi-organ failure, and then of course whatever you do, it doesn't help the kid. Imaging findings are well documented everywhere, so I'm not going to dwell too much time in it. It's now possible in almost every case to actually have a diagnosis on CT and MR. Sometimes as clinicians, neurosurgeons and neurologists and pediatricians, sometimes we tend not to do imaging on very small babies, but it should not be done, and in every single kid who is suspected to have an intracranial vascular malformation should undergo an imaging, CT scan or MR. If they don't exist in your center, you should not hesitate to refer them to a center which is doing pediatric MR with the machinery. MR is of course very good. It will give us all the information that we require before we treat these kids as far as the brain is concerned. We look at the ventricles, we look at the thinning parenchyma, we look at any changes which happen in the parenchyma, and of course we know if by treating the kid, if we are really going to help or it might be too late. In classification, why should we have classification? We should have classification because all of us treating these or looking at these kids should have the same language. It should not happen that someone is describing something over the phone and he thinks it is something when it's actually something else. So all of us should use the same language. It should be a classification known to everyone. Of course, that's the only way that we will have our records and we will know what we are doing with all types of classifications and all types of diseases. It shows us, when we have our records, it shows us what is the natural history and what is the history. How do they do in your own hands? So classification is important. Sometimes it's a compromise, but it's a good compromise. So now let's go after classification to the treatment, where there are general aspects of it, some specific aspects regarding some of the lesions, and I'll try and show some cases and some tips if I can. Now, the technical aspects in pediatric age group, they remain the same in pediatric age group because they are small kids. They cannot take too much contrast. It's difficult to puncture small femoral arteries. So the best time to puncture a femoral artery in a kid is around 6 months. So if we can get the kid to grow up to 6 months without undergoing significant damage to the brain, then that is probably the best time that we can intervene. Because the kid is big enough, the kid is well enough, and we can get inside the baby, that is the vascular system of the baby, much better than, say, a neonate. We have to pay attention to the contrast that we use. So mostly we should have the diagnosis beforehand. And when we have the diagnosis, we should know that which artery. We just confirm it by doing 1 or 2 injections. If you have a biplanar with you, it helps immensely, especially in doing kids angiography and treatment, because in 1 injection you have got 2 projections. So in couple of injections you have confirmed, you have known what you're dealing with, and then you get inside and try and treat them. If it is difficult dealing with a neonate, and if it's difficult to get inside the femoral artery, do not hesitate to call your pediatric cardiologist, because he is doing it day in and day out. The second thing, the trick that we can do as radiologists is probably get the ultrasound guy, and he will show you, however small the baby is, he will show you where the femoral artery is. And sometimes it's easier that he holds the probe in one hand, and with his other hand, with all, of course, the precautions taken, with his other hand he can actually puncture the femoral artery, and then you take over. And that way you won't miss that puncture nemula. That kind of thing happens very rarely. So how do we get in? Mostly we use a 5 French sheets, micropuncture sets, to get in small kids' femoral arteries. We use 4 French diagnostic catheters and 5 French guiding catheters when we treat. And the microcatheters and the micro-wires remain exactly the same, and we use is 100 units per kg. Post-embolic management, when we embolize, most of our patients are admitted under our care, except the pediatric patients, because we know very, very little about their management. Pediatric patients should be admitted in a pediatric unit, and you should have, as the situation may be, the ventilators and the IPCUs, pediatric intensive care units. And the pediatricians know the drugs and the management much, much better than us. So these kids have to be admitted in a pediatric. So now let's go to some of the cases and patient, which is a deep AVM, which is draining into the vein of Galen, and because of which the vein of Galen gets dilated because of excess blood flow. There are 2 types, as I said, the mural type and the choroidal type. The mural type is our personal favorite. It's a single hole fistula. 2 or 3 arteries can converge on a single hole and pump in lots of fast flowing blood inside a dilated vein, and of course that can drain into the straight sinus or the falcine sinus. The choroidal type is much more complex. It's difficult to treat. It's not a single hole fistula. It's a multi-hole fistula, multiple arteries, maybe 1 vein or multiple veins. So obviously there is not a single target for the choroidal type. It's more difficult, and that's why it has to be treated differently. What happens? Why does the vein of Galen or its precursor get aneurysmally dilated? It happens because there is a fistula which is commonly fed by either the marginal perforators or the choroidals, posterior choroidals more often than anterior choroidals. And because of this shunting of blood, the precursor of vein of Galen, it gets dilated. Vein of Galen, or the deep system in kids, actually has a balance as far as the draining out of the blood is concerned in the brain with the superior sinus. So the SSS has to take the brunt of the entire blood flow, because the vein of Galen is so high flow, it is not taking any part in the normal drainage of the brain.